Trauma is a near universal experience of individuals with behavioral health problems. According to the U.S. Department of Health and Human Services Office on Women's Health, between 55 and 99% of women in substance use treatment and between 85 and 95% of women in the public mental health system report a history of trauma, with the abuse most commonly having occurred in childhood. The Adverse Childhood Experiences study conducted by the Centers for Disease Control and Prevention and Kaiser Permanente is one of the largest investigations ever conducted to assess associations between childhood maltreatment and later life health and well-being. Almost 2/3 of the study participants reported at least one adverse childhood experience of physical or sexual abuse, neglect, or family dysfunction, and more than 1 in 5 reported 3 or more such experience. An individual's experience of trauma impacts every area of their functioning: physical, mental, behavioral, social, spiritual. The ACE study revealed the economic cost of untreated trauma-related alcohol and drug abuse alone were estimated at $161 billion. The human costs are incalculable. Trauma is shrouded in secrecy and denial and is often ignored. When we don't ask about trauma in behavioral health care, harm is done or abuse is intentionally recreated by the use of forced medication, seclusion, or restraints. The good news is trauma is treatable. There are many evidence-based models and promising practices designed for specific population, types of trauma, and behavioral health manifestations. This lesson is about trauma-informed care. The lesson includes this video presentation, additional material that is located in the lesson media section of this lesson, and, after completing the lesson, a quiz. In order to complete the lesson successfully, you will need to have a passing score of at least 70% on the quiz. Good luck. According to SAMHSA's Trauma and Justice Strategic Initiative, trauma results from an event, a series of events, or a set of circumstances that is experienced by an individual as physically or emotionally harmful or threatening, and that has lasting adverse effects on the individual's functioning and physical, social, emotional, or spiritual well-being. Trauma can affect people of every race, ethnicity, age, sexual orientation, gender, psychosocial background, and geographic region. A traumatic experience can be a single event, a series of events, and/or a chronic condition. Traumas can affect individuals, families, groups, communities, specific cultures, and generations. It generally overwhelms an individual's or community's resources to cope, and it often ignites the fight, flight, or freeze reaction at the time of the event. It frequently produces a sense of fear, vulnerability, and helplessness. Often, traumatic events are unexpected. Individuals may experience the traumatic event directly, witness an event, feel threatened, or hear about an event that affects someone they know. Events may be human-made, such as mechanical error that causes a disaster, war, terrorism, sexual abuse, or violence, or they can be products of nature, such as flooding, hurricane, tornadoes. Trauma can occur at any age or developmental stage, and often events that occur outside expected life stages are perceived as traumatic, such as a child dying before a parent, cancer as a teen, personal illness, or job loss before retirement. It is not just the event itself that determines whether something is traumatic, but also the individual's experience of the event. Two people may be exposed to the same event or series of events, but experience and interpret these events in vastly different ways. Various biopsychosocial and cultural factors influence an individual's immediate response and long-term reactions to trauma. For most, regardless of the severity of the trauma, the immediate or enduring effects of trauma are met with resilience, the ability to rise above the circumstances or to meet the challenges with fortitude. For some people, reactions to a traumatic event are temporary, whereas others have prolonged reaction that move from acute symptoms to more severe, prolonged, and enduring mental health consequences. Additionally, medical problems may result. Others do not meet established criteria for post-traumatic stress or other mental disorders, but encounter significant trauma-related symptoms or culturally expressed symptoms of trauma. For that reason, even if an individual does not meet diagnostic criteria for a trauma-related disorder, it is important to recognize that trauma may still affect his or her life in significant ways. The concepts of trauma-informed care have evolved over the past 30 years from a variety of streams of thought and innovation. They are now being applied in a wide range of settings, from mental health and substance abuse treatment providers to child welfare systems, and even schools and criminal justice institutions. In the simplest terms, the concept of trauma-informed care is straightforward. If professionals were to pause and consider the role trauma and lingering traumatic stress plays in the lives of the specific client population served by an individual, professional, organization, or an entire system, how would they behave differently? What steps would they take to avoid, or at least to minimize, adding new stress or inadvertently reminding their clients of their past traumas? How can they better help their traumatized clients heal? In effect, by looking at how the entire system is organized and services are delivered through a trauma lens, what should be done differently? The answer can be used to guide practice, policy, procedures, and even how the physical caring environment is structured. Long before anyone used the term trauma-informed, caring professionals and committed volunteers were instinctively acting in a trauma-informed manner. Much of this was influenced by the emergence of the feminist movement and the increasingly influential voice of survivors of interpersonal trauma, as seen in the rape crisis centers and the domestic violence movements of the 1970s, and the dramatic growth of child advocacy centers and multidisciplinary teams in child abuse in the 1980s. These natural incubators for trauma-informed innovation and practice were married in the 1990s with a growing body of science and trauma-specific research into how human beings respond in the aftermath of traumatic events, and how professionals and concerned activists could help them move toward recovery. The stream of research began with the interest in combat-related post-traumatic stress after the Vietnam War. By the mid-80s, the focus had expanded and was adopted by the wider mental health community as a relevant construct for understanding the cascade of symptoms often noted after rapes, shootings, and other major traumatic life events. In 1985, the International Society for Traumatic Stress was founded in the United States and served as a focal point for professionals searching for answers to support highly traumatized populations. By 1989, the United States Department of Veterans Affairs had created the National Center for Post-Traumatic Stress Disorder. In the 1990s, the Substance Abuse and Mental Health Services Administration recognized the role of trauma in a significant number of women's issues and gender-specific treatments. Over the next 20 years, a huge expansion of knowledge about trauma and traumatic stress occurred. This included not only better diagnostic criteria, but the development of empirically tested treatments for post-traumatic stress disorder and other related trauma symptoms. At its basic, trauma-informed care is a strength-based framework that is grounded in an understanding of and a responsiveness to the impact of trauma. Treatment professionals should always consider the role of trauma in the individual's life. Programs emphasize physical, psychological, and emotional safety for both the providers and for the survivors of traumatic events. And finally, the programs create opportunities for survivors to rebuild a sense of control over their lives and a sense of empowerment. Defining trauma is not without its controversies. Those who would approach it from a clinical perspective tend to view trauma as a combination of terrible event or series of events that involve real or perceived threats of death or serious injury, or threat to the physical integrity of the person or others, and from which that person experiences overwhelming fear, hopelessness, helplessness, or horror. This type of overwhelming stress, especially when it occurs over and over, as is common in many individuals served by the human services community, can create significant long-term impacts, including changes in the physiology of the brains of developing children. Some survivors of trauma, however, favor a definition that places greater emphasis on the subjective experience and the level of stress an individual perceives, independent of an event or series of events that threaten the individual with death, serious injury, or loss of their physical integrity, such as highly emotional arguments with a family member. On this slide, we have provided you with a list of items that are recognized, or occurrences that are recognized, as traumatic events. We will go on to talk specifically about a couple of them. I'll give you a minute just to review this list. Racial trauma, a form of race-based stress, refers to people of color's reactions to dangerous events and real or perceived experiences of racial discrimination. Such experiences may include threats of harm and injury, humiliating and shaming events, and witnessing racial discrimination toward other people of color. Although similar to post-traumatic stress disorder, racial trauma is unique in that it involves ongoing individual and collective injuries due to exposure and re-exposure to race-based stress. In 2000, the U.S. Surgeon General stated that racial and ethnic health disparities were likely due to racism. A growing clinical and empirical literature attests that people of color experiences with racism, discrimination, and microaggressions affect their mental and physical health. For example, Findings from a meta-analysis indicate at least a small to moderate link between exposure to racism and psychological and physical distress. Given the presence of racial discrimination and a recent rise in hate crimes, it is important to document the nature and consequences of racial discrimination and also the factors promoting healing from racial trauma associated with these personal, vicarious, and collective experiences. Racial trauma, or race-based stress, refers to the events of danger related to real or perceived experience of racial discrimination. These include threats of harm, humiliating and shaming events, and witnessing harm to others due to real or perceived racism. Although African Americans are more exposed to racial discrimination than are other ethnic groups, many indigenous people, Latinas, and Asian Americans significantly suffer from race-based stress. Intersectional oppressions such as racial, gender, sexual orientation, and microaggressions contribute to the cumulative effects of racial trauma. Racism and ethno-violence can be life-threatening to persons of color due to their exposure to racial aggressions, vicarious traumatization, and the invisibility of racial trauma's historic roots. Cumulative racial trauma can leave scars for those who are dehumanized. Historical and cultural trauma is multi-generational trauma experienced by a specific cultural, racial, or ethnic group. It is related to major events that oppressed a particular group of people because of their status, such as slavery, the Holocaust, forced migration, and the violent colonization of Native Americans. While many in such a group will experience no effects of the historical trauma, others may experience poor overall physical and behavioral health, including low self-esteem, depression, self-destructive behavior, a marked propensity for violent or aggressive behavior, substance misuse and addiction, and high rates of suicide and cardiovascular disease. Acute problems of domestic violence or alcohol abuse that are not directly linked to historical trauma may be exacerbated by living in a community with unaddressed grief and behavioral health needs. Parents' experience of trauma may disrupt typical parenting skills and contribute to behavioral problems in children. Compounding this familial or intergenerational trauma, historical trauma often involves the additional challenge of a damaged cultural identity. Mental health practitioners first described historical trauma among the descendants of the Holocaust and the children of Japanese Americans interned during World War II. The children and grandchildren of survivors commonly experience attachment issues and isolation by their parents. Considerable work has also been done with communities of Native Americans who experienced repeated massacres and the forced removal of children to federal and mission boarding and day schools. From her work with tribal communities, clinician and researcher Maria Yellowhorse Braveheart describes historical trauma as the cumulative emotional and psychological wounding over the lifespan and across generations emanating from massive group trauma experience. Similarly, African Americans experienced generations of slavery, segregation, and institutionalized racism that has contributed to physical, psychological, and spiritual trauma. For members of any of these communities, daily reminders of racial discrimination can exacerbate individual responses to trauma. A traumatic event is a frightening, dangerous, or violent event that poses a threat to a child's life or bodily integrity. Witnessing a traumatic event that threatens the life or physical security of a loved one can also be traumatic. This is particularly important for young children, as their sense of safety depends on the perceived safety of their attachment figures. Trauma reactions may persist long after the event. The intensity of physical and emotional responses can overwhelm children. Several factors affect how a child will respond to a traumatic event. These include the age and developmental level of the child, how the child perceived the danger, the role the child played in the event, and any previous trauma that the child has experienced. The protective responses of adults involved in the child's life, or lack thereof, also affect how the child responds to a traumatic event. From birth to early adulthood, the brain of the child or young person is developing rapidly and changing. Traumatic events can cause lasting changes in the brain, especially in children, teenagers, and adults under the age of 25. How a child heals or doesn't heal from trauma may impact the child's development, and the effects can last into adulthood. The term adverse childhood experiences came from a medical study in 1999 that measured certain childhood experiences in over 17,000 people. The study was a breakthrough for understanding the connection between childhood stress, trauma, and health. This study asked medical patients if, when they were children, they experienced physical, sexual, or emotional abuse or neglect. The patients were also asked if they experienced other specific issues as children, including a mother who was treated violently, substance abuse in the home, a home member with a mental illness, parental separation or divorce, or a home member who was incarcerated. These experiences were linked to increased risk of risky health behaviors, chronic health conditions, low life potential, and early death. The study found that adverse childhood experiences are common. 64% of the participants in the study reported experiencing at least one adverse childhood experience. More than 20% of the respondents reported 3 or more adverse childhood experiences. There are several types of trauma. Acute trauma is a one-time traumatic event. Acute trauma is usually short-term, and recovery is likely. Some examples of acute trauma are an automobile accident or a natural disaster such as flood or a hurricane. Chronic trauma describes multiple traumatic events, which may vary in circumstance. For example, a child may be a victim of a physical assault at school, then be in a car accident, and then endure medical trauma related to the accident. Chronic trauma can have a cumulative effect. Complex trauma often begins early in life and may impact a child's development. It can also affect the ability to form secure attachment bonds, a main source of safety and stability. Events that can cause complex trauma are severe and often invasive and interpersonal. For example, ongoing abuse by a parent or profound neglect. Complex trauma is often related to relational trauma. It occurs when a parent or primary caregiver is the cause of traumatic stress, abuse, or neglect in early childhood. Infants and young children rely on their parents and primary caregivers to meet their needs, including feeding, soothing, and bonding. When primary needs are not met or attachment bonds are unhealthy or broken, a child's brain changes. These changes may negatively impact development and coping skills into adulthood. Trauma can have significant impact on the brain, which affects the development of children, adolescents, and into adulthood. In early childhood, trauma can reduce the size of the cortex, which controls complex functions such as language and memory. It can also impact the brain's ability to work between the hemispheres. This includes the parts of the brain that control emotions, which can lead to impaired ability to manage or regulate emotions as children grow older. This may also lead to a child feeling constantly fearful and unsafe. In school-age children, trauma can impact the parts of the brain that are responsible for managing fears, learning, and impulse control. These children may also experience problems managing behavior or learning, disrupted sleeping patterns, or significant difficulty in relationships with others, including caregivers, families, and siblings. In adolescence, trauma can impact the development of the prefrontal cortex of the brain, which is responsible for connecting behaviors and consequences, problem solving, inhibitions, and impulse control. An underdeveloped prefrontal cortex increases the likelihood of risk-taking behavior, poor decision-making, poor school performance, and involvement in criminal activity. When a child does not receive successful intervention for trauma, they are more likely to experience long-term effects into adulthood. Positive and negative coping skills from childhood continue into adulthood. When childhood trauma is not healed, individuals may continue to live life in a conscious or unconscious state of fear, alarm, depression, or dissociation. Trauma-informed care involves a broad understanding of traumatic stress reactions and common responses to trauma. Providers need to understand how trauma can affect treatment presentation, engagement, and the outcome of behavioral health services. Trauma, including one-time, multiple, or long-lasting repetitive events, affects everyone differently. Some individuals may clearly display criteria associated with post-traumatic stress disorder, but many more individuals will exhibit resilient responses or brief subclinical symptoms or consequences that fall outside of the diagnostic criteria. The impact of trauma can be subtle, insidious, or outright destructive. How an event affects an individual depends on many factors, including characteristics of the individual, the type and characteristics of the event, developmental processes, the meaning of trauma, and sociocultural factors. Survivors' immediate reactions in the aftermath of trauma are quite complicated and are affected by their own experiences, the accessibility of natural supports and healers, their coping and life skills, and those of immediate family, and the responses of the larger community in which they live. Although reactions range in severity, even the most acute responses are natural responses to manage trauma. They are not a sign of psychopathology. Coping styles vary from action-oriented to reflective, and from emotionally expressive to reticent. Clinically, a response style is less important than the degree to which coping efforts successfully allow one to continue necessary activities, regulate emotions, sustain self-esteem, and maintain and enjoy interpersonal contacts. Initial reactions to trauma can include exhaustion, confusion, sadness, anxiety, agitation, numbness, dissociation, confusion, physical arousal, and blunted affect. Most responses are normal in that they affect most survivors and are socially acceptable, psychologically effective, and self-limited. Indicators of more severe responses include continuous distress without periods of relative calm or rest, severe dissociation symptoms, and intense intrusive recollections that continue despite a return to safety. Delayed responses to trauma can include persistent fatigue, sleep disorders, nightmares, fear of reoccurrence, anxiety focused on flashbacks, depression, and avoidance of emotions, sensations, or activities that are associated with the trauma. A variety of reactions are often reported or observed after trauma. Most survivors exhibit immediate reaction, yet these typically resolve without severe long-term consequences. This is because most trauma survivors are highly resilient and develop appropriate coping strategies, including the use of social supports, to deal with the aftermath and effects of trauma. Most recover with time, show minimal distress, and function effectively across major life areas and developmental stages. Even so, clients who show little impairment may still have subclinical symptoms or symptoms that do not fit diagnostic criteria for acute stress disorder or post-traumatic stress disorder. Only a small percentage of people with a history of trauma show impairment in symptoms that meet the criteria for trauma-related stress disorders, including mood and anxiety disorders. Trauma-informed care is an approach in the human services field that assumes that an individual is more likely than not to have a history of trauma. Trauma-informed care recognizes the presence of trauma symptoms and acknowledges the role trauma may play in an individual's life, including service staff. On an organizational or systemic level, trauma-informed care changes organizational culture to emphasize respecting and appropriately responding to the effects of trauma at all levels. Similar to the change in general protocol regarding universal precautions, trauma-informed care practice and awareness becomes almost second nature and pervasive in all service responses. Trauma-informed care requires a system to make a paradigm shift from asking what is wrong with this person to what has happened to this person. The intention of trauma-informed care is not to treat symptoms or issues related to sexual, physical, or emotional abuse or any other form of trauma, but rather to provide support services in a way that is accessible and appropriate to those who may have experienced trauma. When service systems operating procedures do not use a trauma-informed approach, the possibility for triggering or exacerbating trauma symptoms and re-traumatizing individuals increases. A trauma-informed care approach strives to understand the whole of an individual who is seeking services. When trauma occurs, it affects an individual's sense of self, their sense of others, and their beliefs about the world. These beliefs can directly impact an individual's ability or motivation to connect with and utilize support service. A system utilizing a trauma-informed care approach realizes the direct impact that trauma can have on access to service and responds by changing policies and procedures and practices to minimize potential barriers. A system utilizing a trauma-informed approach also fully integrates knowledge about trauma into all aspects of services and trains staff to recognize the signs and symptoms of trauma and thus avoid any possibility of re-traumatization. Re-traumatization is any situation or environment that resembles an individual's trauma, literally or symbolically, which then triggers difficult feelings and reactions associated with the original trauma. The potential for re-traumatization exists in all systems and in all levels of care, individuals, staff, and systems or organizations. Retraumatization is often unintentional. There are some obvious practices that could be re-traumatizing, such as the use of restraints or isolation. However, less obvious practices or situations that involve specific smells, sounds, or types of interactions may cause individuals to feel re-traumatized. Re-traumatization is a significant concern, as individuals who are traumatized multiple times frequently have exacerbated trauma-related symptoms compared to those who have experienced a single trauma. Individuals with multiple trauma experiences often exhibit a decreased willingness to engage in services. Re-traumatization may also occur when interfacing with individuals who have a history of historical, intergenerational, and/or cultural trauma experiences. I found this chart as I was doing research for this presentation and wanted to share it with you because it identifies several systems issues that may be defined in policies or procedures, and also relationship issues, which the person served may experience as power and control. Under the systems issues, one of the re-traumatizing events is having the person to continually retell their story, specifically the story around the trauma. How many of us have systems where a person completes various intake and assessment documents where they have to repeat their story over and over? The second system issue is being treated impersonally. If the person does not feel like they are being treated as an individual, as a person, they may feel dehumanized, which may be a part of their original trauma. Likewise, being seen as a label or a diagnosis tells the individual that there is something fundamentally wrong with them, and that may have been the message in the original trauma. Any procedures that require the individual to undress may be a re-traumatization, especially if the original trauma was of a sexual nature. The lack of the individual's choice in services or treatment may be re-traumatizing because it reminds the person of the powerlessness that they experienced during the original traumatic event. And finally, in terms of systems issues, not having an opportunity to give feedback about their experience with services, again, is a reminder of the powerlessness, that their voice doesn't matter. And if that has any relativity to the original trauma, that experience may be re-traumatizing. Under the relationship issues, patients will feel re-traumatized when they're not being seen or heard. If the individual experiences not being listened to, then they are likely to feel re-traumatized. Individuals who have experienced trauma have a keen sense of identifying when their trust is being violated, because the original trauma may have been a violation of trust. And so we want to be very, very sure that we maintain the trust that we provide with the individuals receiving services. Failure to ensure the emotional safety of the individual. Making sure that the treatment relationship, the service relationship, is a safe place for the individual. Non-collaborative practices, telling the person what to do, again reminds the individual of that powerlessness. Doing things for the person rather than with the person communicates to the person served that they do not have the ability to do this for themselves, again reminding them of the original powerlessness in the original trauma. And finally, any type of punitive treatment Coercive practices or oppressive language will very likely re-traumatize the individual. Trauma-informed care follows 5 guiding principles that serve as a framework for how service providers and systems of care can work to reduce the likelihood of re-traumatization. These principles are generalizable across a variety of service settings. Rather than providing a set of practices and procedures, the principles can be interpreted and applied in ways that are appropriate for a specific type of service setting. The 5 guiding principles are safety, choice, collaboration, trustworthiness, and empowerment. Ensuring that the physical and emotional safety of an individual is addressed is the first important step to providing trauma-informed care. Next, the individual needs to know that the provider is trustworthy. Trustworthiness can be evident in the establishment and consistency of boundaries and the clarity of what is expected in regards to tasks. Additionally, the more choice an individual has and the more control they have over their service experience through a collaborative effort with service providers, the more likely the individual will participate in services and the more effective those services may be. Finally, focusing on an individual's strengths and empowering them to build on those strengths while developing stronger coping skills provides a healthy foundation for individuals to fall back on if and when they stop receiving services. The need to create a safe environment is not new to providers. It involves an agency-wide effort supported by effective policies and procedures. However, creating safety within a trauma-informed framework far exceeds the standard expectation of physical plant safety, security, policies and procedures, emergency management and disaster planning, and adherence to client rights. Providers must be responsive and adapt the environment to establish and support clients' sense of both physical and emotional safety. Beyond anticipating that various environmental stimuli within a program may generate strong emotions and reactions in a trauma survivor, and implementing strategies to help clients cope with triggers that evoke their experiences with trauma, other key elements in establishing a safe environment include consistency in client interactions and treatment processes, following through with what has been reviewed or agreed upon in meetings, and dependability. Neither providers nor processes are always perfect. Sometimes we unintentionally relay information inaccurately or inconsistently to clients or other staff members. Other times, clients mishear something, or extenuating circumstances prevent us from responding as promised. Creating safety is not about getting it right all the time. It's about how consistently and forthrightly we handle situations with a client when circumstances provoke feelings of being vulnerable or unsafe. Honest and compassionate communication that conveys a sense of handling the situation together generates safety. It is equally important that safety extends beyond the client. Staff members, including peer support specialists, need to be able to count on the agency to be responsive to and maintain their safety within the environment as well. By incorporating an organizational ethos that recognizes the importance of practices that promote physical safety and emotional well-being, behavioral health staff members may be more likely to seek support and supervision when needed, and to comply with clinical and programmatic practices that minimize risks for themselves and their clients. Beyond an attitudinal promotion of safety, Organizational leaders need to consider and create avenues of professional development and assistance that will give their staff the means to seek support and process distressing circumstances or events that occur within the agency or among their clientele, such as consultation and supervision, formal or informal process to debrief service providers about difficult clinical issues, and referral processes for client psychological evaluations and employee assistance for staff. Organizational practices are only effective if supported by unswerving trauma awareness, training, and education among staff. Not every client who has experienced trauma and is engaged in behavioral health services wants or sees the need for trauma-informed or trauma-specific treatment. Clients may think that they've already dealt with their trauma adequately, or they may believe that the effects of past trauma cause minimal distress for them. Other clients may voice the same sentiments, but without conviction, instead using avoidant behavior to deter distressing symptoms or reactions. Still others may struggle to see the role of trauma in their presenting challenges, not connecting their past traumatic experiences with other, more current difficulties. Simply the idea of acknowledging trauma-related experiences and/or stress reactions may be too frightening or overwhelming for some clients, and others may fear that their reactions will be dismissed. On the other hand, some individuals want so much to dispense with their traumatic experiences and reactions that they hurriedly and repeatedly disclose their experiences before establishing a sufficiently safe environment or learning effective coping strategies to offset distress and other effects of retraumatization. As these examples show, not everyone affected by trauma will approach trauma-informed services or recognize the impact of trauma in their lives in the same manner. This can be challenging to service providers who are knowledgeable about the impact of trauma and who perceive the importance of addressing trauma and its effects with clients. As with knowing that different clients may be at different levels of awareness or stages of change in substance abuse treatment services, we should acknowledge that people affected by trauma present an array of reactions, various levels of trauma awareness, and different degrees of urgency in their need to address trauma. Appreciating clients' perception of their presenting problems and viewing their responses to the impact of trauma as adaptive, even when you believe their methods of dealing with trauma to be detrimental, are equally important elements of trauma-informed care. By taking the time to engage with clients and understand the ways they have perceived, adjusted to, and responded to traumatic experiences, providers are more likely to project the message that clients possess valuable personal expertise and knowledge about their own presenting problems. This shifts the viewpoint from providers know best to the more collaborative, together we can find solutions. How often have you heard from clients that they don't believe they can handle symptoms that emerge from re-experiencing traumatic cues or memories? Have you ever heard clients state that they can't trust themselves or their reactions, or they never know when they're going to be triggered or how they're going to react? How confident would you feel about yourself if at any time a loud noise could initiate an immediate attempt to hide, duck, or dive behind something? Traumatic experiences have traditionally been described as exposure to events that cause intense fear, helplessness, horror, or feelings of loss of control. Participation in behavioral health services should not mirror these aspects of traumatic experience. Working collaboratively to facilitate clients' sense of control and to maximize their autonomy and choices throughout the treatment process, including treatment planning, is crucial in trauma-informed service. For some individuals, gaining a sense of control and empowerment, along with understanding traumatic stress reactions, may be pivotal ingredients for recovery. By creating opportunities for empowerment, behavioral health providers help reinforce clients' sense of competence, which is often eroded by trauma and prolonged traumatic stress reactions. Keep in mind that treatment strategies and procedures that prioritize client choice and control need not focus solely on major life decisions or treatment planning. We can apply such approaches to common tasks and everyday interactions between staff and consumers. Finally, organizations need to reinforce the importance of staff autonomy, choice, and sense of control. What resources can staff members access, and what choices are available to them in processing emotionally charged content or events in treatment? How often do administrators and supervisors seek out feedback on how to handle problematic situations? Think about the parallel between administration and staff members versus staff members and clients. Often, the same philosophy, attitudes, and behaviors conveyed to staff members by administrative practices are mirrored in staff-client interactions. Simply stated, if staff members do not feel empowered, it will be a challenge for them to value the need for client empowerment. There are three main tenets in creating collaborative relationships and opportunities for participation. The first is to ensure that the provider-client relationship is collaborative, regardless of setting or service. Agency staff members cannot make decisions pertaining to the interventions or involvement in community services autocratically. Instead, they should develop trauma-informed individualized care plans or treatment plans collaboratively with the client and, when appropriate, with family and caregivers. The non-authoritarian approach that characterizes trauma-informed care views clients as the experts in their own lives and current struggles, thereby emphasizing that clients and providers can learn from one another. The second tenet is to build collaboration beyond the provider-client relationship. Building ongoing relationships across the service system, provider networks, and the local community enhances trauma-informed care continuity as clients move from one level of service to the next, or when they are involved in multiple services at one time. It also allows us to learn about resources available in our communities, in the service system, and to connect with providers who may have more advanced training in trauma-specific intervention and services. The third tenet emphasizes the need to ensure client or consumer representation and participation in behavioral health program development, planning, and evaluation, as well as in the professional development of behavioral health workers. To achieve trauma-informed competence in an organization or across system, clients need to play an active role. This starts with providing program feedback. However, consumer involvement should not end there. Rather, it should be encouraged throughout the implementation of trauma-informed services. So too, clients, potential clients, their families, and the community should be invited to participate in forming any behavioral health organization's plans to improve trauma-informed competence, provide trauma-informed care, and design relevant treatment services and organizational policies and procedures. Trauma-informed principles and practices generated without the input of people affected by trauma are difficult to apply effectively. Likewise, staff trainings and presentations should include individuals who have felt the impact of trauma. Their participation reaches past the purely cognitive aspects of such education to offer a personal perspective on the strengths and resilience of people who have experienced trauma. The involvement of trauma survivors in behavioral health education lends a human face to subject matter that is all too easily made cerebral by some staff members in an attempt to avoid the emotionality of the topic. Consumer participation also means giving clients and consumers the chance to obtain state training and certification, as well as employment in behavioral health settings as peer specialists. Programs that incorporate peer support services reinforce a powerful message that provider-consumer partnership is important and that consumers are valued. Peer support specialists are self-identified individuals who have progressed in their own recovery from alcohol dependence, drug addiction, and/or a mental health disorder, and work within behavioral health programs or at peer support centers to assist others with similar disorders and/or life experiences. Tasks and responsibilities may include leading a peer support group, modeling effective coping or help seeking and self-care strategies, helping clients practice new skills or monitor progress, promoting positive self-image to combat clients' potentially negative feelings about themselves and the discrimination that they perceive in the program or community, handling case management tasks, advocating for program changes, and representing a voice of hope that views recovery as possible. We cannot build an effective helping relationship without trust. We can find lots of literature about the importance of trust, but it is more difficult to find practical steps for building and maintaining trust. What is presented here are several behaviors that help to build and maintain trust. First, be true to your word and follow through with your actions. The point of building trust is for others to believe what you say. Keep in mind, however, that building trust requires not only keeping the promises you make, but also not making promises you're unable to keep. Keeping your word shows others what they can expect from you, and they'll be more likely to treat you with respect, developing further trust in the process. Number 2, learn how to communicate effectively with others. Poor communication is a major reason why relationships break down. Good communication includes being clear about what you have and have not committed to and what has been agreed upon. Building trust is not without risk. It involves allowing both you and the others taking risks to prove trustworthiness. To navigate this, effective communication is the key. Without it, you may find the message you've intended to send aren't the messages that are received. Third, this one's simple, always be honest. The message you convey should always be the truth. If you are caught telling a lie, no matter how small, your trustworthiness will be diminished. Number 4, help people when you can. Helping another person, even if it provides no benefit to you, builds trust. Authentic kindness helps to build trust. Number 5, always do what you believe to be right. Doing something purely for approval means sacrificing your own values and beliefs. This decreases trust in yourself, your values, and your beliefs. Always doing what you believe is right, even when others may disagree, will lead others to respect your honesty. Interestingly, when building trust, you must be willing to upset others on occasion. People tend not to trust those who simply say whatever they think others want to hear. And finally, Admit your mistakes. When you attempt to hide your mistakes, people know that you're being dishonest. By being open, you show your vulnerable side, and this helps build trust with other people. This is because they perceive you to be more like them. Everyone makes mistakes. If you pretend that you never make mistakes, you'll make it difficult for others to trust you because you have created an unnecessary difference between the two of you. When all that a person sees is the perfection in your work, they likely won't trust you. Fostering individual strengths is a key step in prevention when working with people who have been exposed to trauma. It is also an essential intervention strategy, one that builds on the individual's existing resources and views him or her as a resourceful, resilient survivor. Individuals who have experienced trauma develop many strategies and/or behaviors to adapt to its emotional, cognitive, spiritual, and physical consequences. Some behaviors may be effective across time, whereas others may eventually produce difficulties and disrupt the healing process. Traditionally, behavioral health services have tended to focus on presenting problems, risk factors, and symptoms in an attempt to prevent negative outcomes, provide relief, increase clients' level of functioning, and facilitate healing. However, focusing too much on these areas can undermine the client's sense of competence and hope. Targeting only presenting problems and symptoms does not provide individuals with an opportunity to see their own resourcefulness in managing very stressful and difficult experiences. It is important for providers to engage in interventions using a balanced approach that targets the strengths clients have developed to survive their experience and to thrive in recovery. A strength-based, resilience-minded approach lets trauma survivors begin to acknowledge and appreciate their fortitude and the behaviors that help them survive. Trauma-informed services build a foundation on which individuals can begin to explore the role of trauma in their lives. Such service can also help determine how to best address and tailor interventions to meet their needs. Prevention, mental health, and substance abuse services should include teaching clients about how trauma can affect their lives. These services should also focus on developing self-care skills, coping strategies, supportive networks, and a sense of competence. Building trauma resistance skills begins with normalizing the symptoms of traumatic stress and helping clients who have experienced trauma connect the dots between current problems and past trauma where appropriate. Nevertheless, trauma-informed care and trauma-specific interventions that focus on skill building should not do so at the expense of acknowledging individuals' strengths, creativity in adapting to trauma, and inherent attributes and tools clients possess to combat the effects of trauma. Some theoretical models that use skill-building strategies base the value of this approach on a deficit perspective. They assume that some individuals lack the necessary tools to manage specific situation, and because of this deficiency, they encounter problems that others with effective skills would not experience. This type of perspective further assumes that to recover, these individuals must learn new coping skills and behaviors. Trauma-informed care, on the other hand, makes the assumption that clients are the experts in their own lives and have learned to adapt and acquire skills to survive. The trauma-informed care approach honors each individual's adaptations and acquired skills, and it helps clients explore how these may not be working as well as they had in the past, and how their current repertoire of strategies may not be as effective as other responses. Finally, what defines recovery from trauma-related symptoms and traumatic stress disorders? Is it the total absence of symptoms or consequences? Does it mean that clients stop having nightmares or being reminded by cues of past trauma? When clients who have experienced trauma enter into a helping relationship to address trauma specifically, they are often looking for a cure, a remission of symptoms, or relief from the pain as quickly as possible. However, they often possess a history of unpredictable symptoms and symptom intensity that reinforces an underlying belief that recovery is not possible. On one hand, clients are looking for a message that they can be cured, while on the other hand, they have serious doubts about the likely success of any intervention. Clients often express ambivalence about dealing with trauma, even if they are fully aware of trauma's effects on their lives. The idea of living with more discomfort as they address the past or as they experiment with alternative ways of dealing with trauma-related symptoms or consequences is not an appealing prospect, and it typically elicits fear. Clients may interpret the uncomfortable feelings as dangerous or unsafe, even in an environment and relationship that is safe and supportive. How do you promote hope and relay a message that recovery is possible? First, maintain consistency in delivering services, promoting and providing safety for clients, and showing respect and compassion within the provider-client relationship. Along with the client's commitment to learning how to create safety for themselves, staff members need to be aware of and circumvent practices that could re-traumatize the client. Projecting hope and reinforcing the belief that recovery is possible extends well beyond the practice of establishing safety. It also encompasses discussing what recovery means and how it looks to clients, as well as identifying how they will know when they've entered into recovery in earnest. Providing hope involves projecting an attitude that recovery is possible. This attitude also involves viewing clients as competent to make changes that will allow them to deal with trauma-related challenges, providing opportunities for them to practice dealing with difficult situations, and normalizing discomfort or difficult emotions, and framing these as manageable rather than dangerous. If we convey this attitude consistently with our clients, they will begin to understand that discomfort is not a signal to avoid, but a sign to engage, and that behavioral, cognitive, and emotional responses to cues associated with previous trauma are a normal part of the recovery process. It's not the absence of responses to such triggers that marks recovery, but rather how clients experience and manage these responses. Clients can also benefit from interacting with others who are further along in their recovery from trauma. Time spent with peer support staff or sharing stories with other trauma survivors who are well on their way to recovery is invaluable. It sends a powerful message that recovery is achievable, that there is no shame in being a trauma survivor, and that there is a future beyond the trauma. Creating a physically and emotionally safe environment, establishing trust and boundaries, supporting autonomy and choice, creating collaborative relationships and participation opportunities, and using a strengths and empowerment-focused perspective to promote resilience are ways in which the principles of trauma-informed care work to reduce re-traumatization and promote healing. A trauma-informed approach also considers and modifies policies, procedures, and service strategies from the top down in order to ensure they are not likely to mirror the common characteristics of traumatic experiences. The Substance Abuse and Mental Health Services Administration recommends that when organizations and systems create a trauma-informed environment, the following 10 implementation domains be considered: governance and leadership, policy, physical environment, engagement and involvement, cross-sector collaboration, screening, assessment, treatment services, training and workforce development, progress monitoring and quality assurance, financing, and evaluation. The manner in which a system or organization views and responds to individual trauma, that of both the person served and the staff, sets the stage for the degree of the severity of the impact of the trauma, as well as the facilitation of the healing and recovery process. Treating all clients in an ethical manner is an expectation of all healthcare providers. It is of special importance when working with clients who have trauma-related disorders, as their trust in others may have been severely shaken. Staff members who work with traumatized individuals on a regular basis have special responsibilities to their clients because of the nature of this work. There are some general principles governing the responsibilities of staff members. First, staff members are responsible for routinely screening clients for traumatic experiences and trauma-related symptoms. Second, staff members have a responsibility to practice the principles of confidentiality in all interaction with clients and to respect clients' wishes not to give up their right to privileged communication. Staff members are responsible for educating clients about the limits of confidentiality and what happens to protected health information, along with the client's privilege when the client signs a release of information or agrees to assign insurance benefits to the provider. Third, staff members must inform their clients that treatment for trauma-related disorders is always voluntary. And finally, fourth, it is the responsibility to maintain appropriate therapeutic boundaries. Maintaining these boundaries is a primary ethical concern for behavioral health professionals. Staff members working with clients who have substance use, trauma-related, and other mental disorders may feel challenged at times to maintain boundaries that create a safe therapeutic container. Some clients, especially those with long-standing disorders, bring a history of client-counselor relationships to counseling. Clients who have been traumatized may need help understanding the roles and responsibilities of both the staff member and the client. Clients with trauma-related conditions may also have special needs in establishing appropriate boundaries in the treatment setting. They may be particularly vulnerable and not understand or appreciate the need for professional boundaries, including not engaging in dual relationships. For example, some clients might experience a staff member's boundary around not giving the client his or her personal phone number as a rejection or abandonment. Cultural considerations may also influence therapeutic boundaries. Clients with trauma histories may be especially vulnerable to counselor behaviors that are inconsistent or that are experienced by the client as boundary violations. Examples of such behavior include being late for appointments, ending sessions early, repeatedly and excessively extending the sessions, canceling or forgetting appointments multiple times, spending time in the session talking about the staff person's own need and life experiences, and exploring opportunities for contact outside the therapeutic relationship. Due to the complex dynamics that can arise in the treatment of clients with trauma history, regularly scheduled clinical supervision where issues of ethics and boundaries can be discussed, is recommended. Although guidelines and codes of ethics are useful tools in helping supervisors and staff members understand the boundaries between themselves and their clients, they are open to interpretation and are context bound. Given these limitations, it is crucial to educate staff members in trauma-informed care settings regarding the boundary issues that may arise for clients who have been traumatized, and to give staff members a conceptual framework for understanding the contextual nature of the boundaries. For example, it would be useful for clinical supervisors to discuss with their staff members the distinction between boundary crossings and boundary violations. A boundary crossing may be defined as a departure from customary norms of practice in relation to psychological, physical, or social space that are harmless, are non-exploitative, and may even support or advance the process. Examples of boundary crossings include taking phone calls from a client between sessions if the client is in crisis, or telling a client a story about the staff member's recovery from trauma with the intention of offering hope that it is possible to recover. A boundary violation is a boundary crossing that is unwanted and dangerous and which exploits the client. That some boundary crossings are inadvisable because of their intent. In other words, they are not done in the service of the patient's well-being and growth, and involve extra gratification for the provider, and or their effect. They are not likely to benefit the patient and entail a significant risk of harm. Two key elements in understanding when a boundary crossing becomes a boundary violation are the intent of the staff member and the damaging effect on the client. Maintaining a standard of practice of non-exploitation of the client is the primary focus for clinical supervisors and staff members in determining when boundary crossings become boundary violations. The demands of providing mental health and substance abuse services exacts a price from behavioral health professionals that cannot be ignored, or as I like to say, caring hurts. The impact of secondary traumatization is that we may become ineffective in our jobs, or worse, emotionally or psychologically impaired. In a study of master's level licensed social workers, 15.2% of the respondents to a survey reported secondary traumatic stress as a result of indirect exposure to trauma material at a level that meets the diagnostic criteria for post-traumatic stress disorder. That rate is almost twice the rate of PTSD in the general population. The author concluded that behavioral health professionals' experience of secondary traumatic stress is a contributing factor in staff turnover and one reason why many behavioral health professionals leave the field. Secondary traumatization of behavioral health workers is a significant organizational issue for clinical supervisors and administrators in substance abuse and mental health treatment programs to address. The organization itself creates a social context with risk factors that can increase the likelihood of professionals experiencing secondary traumatic stress reactions, but it also contains protective factors that can lessen the risk and impact of secondary traumatic stress reactions on staff members. Organizations can lessen the impact of the risk factors associated with working in trauma-informed organization by mixing caseloads to contain clients both with and without trauma-related issues. supporting ongoing training, providing regular clinical supervision, recognizing the work efforts, and offering an empowering work environment in which staff members share in the responsibility of making decisions and can offer input into clinical and program policies that affect their work lives. When organizations support their staff in their work with clients who are traumatized, staff can be more effective, more productive, and feel greater personal and professional satisfaction. In addition, the staff members develop a sense of allegiance toward the organization, thus decreasing staff turnover. If organizations do not provide this support, staff can become demoralized and have fewer emotional and psychological resources to manage the impact of clients' traumatic material and outward behavioral expressions of trauma on their own well-being. Providing staff with the resources to help them build resilience and prevent feeling overwhelmed should be a high priority for administrators and clinical supervisors in trauma-informed care organizations. Individual risk factors that may contribute to the development of secondary traumatic stress, or STS, in behavioral health professionals include pre-existing anxiety or mood disorders, a prior history of personal trauma, high caseloads of clients with trauma-related disorders, being younger in age and new to the field with little clinical experience or training in treating trauma-related conditions, and unhealthy coping styles, including distancing and detachment from clients and coworkers, and a lack of tolerance for strong emotions. Other negative coping strategies include substance abuse, other addictive behaviors, a lack of recreational activities not related to work, and a lack of engagement with social support. Researchers found that providers who engaged in negative coping strategies, such as alcohol or illicit drug use, were more likely to experience intrusive trauma symptoms. Additionally, numerous organizational factors can contribute to the development of secondary traumatic stress in staff who work with clients with trauma-related disorders. These risk factors include organizational constraints, such as the lack of resources for clients, lack of clinical supervision, lack of support from colleagues, and lack of acknowledgement by the organizational culture that secondary traumatization exists and is a normal reaction of staff to client trauma. In a study of 259 individuals providing mental health services, staff who spent more time with clients with trauma-related disorders reported higher levels of traumatic stress symptoms. Staff may be more at risk for developing secondary traumatization if the organization does not allow for balancing the distribution of trauma and non-trauma cases among staff members. Much of the clinical and research literature focuses on individual factors that may lessen the impact of secondary traumatic stress on behavioral health professionals, including male gender, being older, having more years of professional experience, having specialized training in trauma-informed and trauma-specific practices, lacking a personal trauma history, exhibiting personal autonomy in the workplace, using positive personal coping styles, and possessing resilience or the ability to find meaning in stressful life events and to rebound from adversity. Some of these factors, like positive personal coping styles and the ability to find meaning in adversity, can be developed and enhanced through personal growth work, therapy, engagement with spiritual practices and involvement in the spiritual community, and stress reduction strategies like mindfulness meditation. One of the organizational protective factors identified in the literature that may lessen the negative impact of secondary traumatization on behavioral health professionals is providing adequate training in trauma-specific counseling strategies, which increases providers' sense of efficacy in helping clients with trauma-related disorders and reduces the sense of hopelessness that is often a part of the work. Another protective factor is having diverse caseloads of clients. Organizations must determine ways of distributing the workload in order to limit the traumatic exposure of any one worker. This may not only serve to reduce the impact of immediate symptoms, but may also address the potential longitudinal effects. Emotional support from professional colleagues can be a protective factor. Support is associated with less emotional fatigue and depersonalization, along with a sense of greater personal accomplishment. In a study of domestic violence advocates, workers who received more support from professional peers were less likely to experience secondary traumatization. In addition, engagement in relationally based clinical supervision with a trauma-informed supervisor acts as a protective factor. For the worker, good supervision can normalize the feelings and experience, provide support and information about the nature and course of traumatic reactions, help in the identification of transference and countertransference issues, and reveal feelings or symptoms associated with the trauma. Workers who reported engaging, authentic, and empowering relationships with their supervisors were less likely to experience secondary traumatic stress. Thus, it is not simply the frequency and regularity of clinical supervision, but also the quality of supervision and the quality of the supervisor relationship that can lessen the impact of secondary traumatic stress on behavioral health professionals. Engagement with a personal practice of spirituality that provides a sense of connection to a larger perspectives and meaning in life is another protective factor. Behavioral health professionals might find support for enhancing spiritual meaning and connection in church, a meditation group, creative endeavors, or even volunteer work. The key is for staff to develop their own unique resources and practices to enhance a sense of meaningful spirituality in their lives. Clinical supervisors should be aware of spiritual engagement as a protective factor in preventing and lessening the impact of secondary traumatic stress and should support staff in including it in their self-care plans, but they should take care not to promote or reject any particular religious belief system or spiritual practice. Another protective factor that may lessen the impact of the worker's secondary traumatic stress is a culture of empowerment in the organization that offers staff a sense of autonomy, a greater ability to participate in making decisions about policies, and obtaining support and resources that further their professional development. To the degree that organizations can provide a cultural context within which behavioral health professionals have autonomy and feel empowered, they will be able to lessen the impact of secondary traumatic stress on their professional and personal lives. Self-efficacy and empowerment are antidotes to the experience of powerlessness that often accompanies trauma. There are a number of indicators of secondary traumatic stress. The first group includes indications of psychological distress, such as distressing emotions like grief, depression, anxiety, dread, fear, rage, or shame. Intrusive imagery of a client's traumatic material, nightmares, flooding, flashbacks of client disclosures. Numbing or avoidance. Avoidance of working with the client's traumatic material. The person may exhibit somatic issues such as sleep disturbances, headaches, gastrointestinal distress, heart palpitations, and chronic physiological arousal. Additionally, addictive and compulsive behaviors may be present, such as substance abuse, compulsive eating, compulsive working. And finally, under psychological distress is impaired functioning, missed or canceled appointments, decreased use of supervision, decreased ability to engage in self-care, isolation, and alienation. Other indicators fall into a category called cognitive shifts, such as chronic suspicion about others, a heightened sense of vulnerability, an extreme sense of helplessness or exaggerated sense of control over others or situations, loss of personal control or freedom, bitterness or cynicism, blaming the victim or seeing everyone as a victim, witness or clinician guilt if client re-experiences trauma or reenacts trauma during a session, and finally, feeling victimized by the client. A third area of secondary traumatic stress is relational disturbances, such as decreased intimacy and trust in personal and professional relationship, distancing or detachment from clients, which may include labeling clients, pathologizing them, judging them, canceling appointments, or avoiding exploring traumatic material, and over-identification with the client, which may include a sense of being paralyzed by one's own responses to the client's traumatic material, or becoming overly responsible for the client's life. The final category of signs of secondary traumatization are referred to as frame of reference, such as disconnection from one's sense of identity, dramatic change in a person's fundamental beliefs about the world, loss or distortion of values or principles, a previous sense of spirituality as comfort or resource decreases or becomes non-existent, loss of faith in something greater, and finally, existential despair and loneliness. Staff members with unacknowledged secondary traumatic stress can harm clients, themselves, family, and friends by becoming unable to focus on and attend to their needs or those of others. They may feel helpless or cynical and withdraw from support systems. The previous slide describes some emotional, cognitive, and behavioral signs that may indicate that a person is experiencing secondary traumatization. Therefore, it is important for the individual to have awareness of their own mental health, and be aware of any of those signs. Additionally, clinical supervisors should be familiar with the manifestations of secondary traumatic stress in their staff and should address those signs immediately. STAM has developed and revised a self-assessment tool called the Professional Quality of Life Scale that measures indicators of staff member compassion fatigue and compassion satisfaction. Compassion fatigue is best defined as a syndrome consisting of a combination of the symptoms of secondary traumatic stress and professional burnout. Although secondary traumatization as a reaction to exposure to clients' trauma material is similar to PTSD, burnout is a more general type of psychological distress related to the pressures of working in high-stress environments over time. Burnout may be a result of secondary traumatization and or a contributing factor in the development of secondary traumatization. The ProQual includes secondary traumatic stress and burnout scales that have been validated in research studies. This tool can be used in individual and group clinical supervision, trainings on self-care, and team meetings as a way for counselors to check in with themselves on their levels of stress and potential signs of secondary traumatization. The Compassion Satisfaction Scale allows counselors to reflect on their resilience and reminds them of why they chose to work with people with substance use and trauma-related disorders or mental health issues and trauma-related disorders, despite the fact that this work can lead to secondary traumatization. The Compassion Satisfaction Subscale reminds us that we are compassionate, that one of the reasons we're in the helping profession is that we value service to others, and that helping brings meaning and fulfillment to our lives. In light of the intensity of working with clients with co-occurring substance use, mental health, and trauma-related disorders, and the vulnerability of staff to secondary traumatization, a comprehensive, individualized self-care plan is highly recommended. Balance is the key to the development of a self-care plan. A balance between home and work. A balance between focusing on self and others. A balance between rest and activity. Self-care is also about balancing vulnerability, which allows staff to be present and available when clients address intensely painful content, with reasonable efforts to preserve their sense of integrity in situations that may threaten their faith or worldview. A comprehensive self-care plan should include activities that nourish the physical, psychological, mental, emotional, relational, and spiritual aspects of our lives. A self-care plan should include a self-assessment of current coping skills and strategies, and the development of a holistic, comprehensive self-care plan that addresses, as I said previously, physical self-care, psychological self-care, emotional self-care, and spiritual self-care. Activities that may help behavioral health workers find balance and cope with the stress of working with clients with trauma-related disorders include talking with colleagues about difficult situations, attending workshops, participating in social activities with family and friends, exercising, limiting client sessions, balancing caseloads to include clients with and without trauma histories, making sure to take vacations, taking breaks during the workday, listening to music, walking in nature, and seeking emotional support in both their professional and personal lives. In addition, regular clinical supervision and personal therapy can be positive coping strategies for lessening the impact of secondary traumatic stress on staff. Still, each staff member is unique, and a self-care approach that is helpful to one may not be helpful to another. Sakvikny and colleagues describe 3 essential components, the ABCs of self-care, that effectively address the negative impact of secondary traumatization on counselors. The A is for awareness. Awareness of one's needs, one's limits, feelings, and internal and external resources. Awareness involves mindful, non-judgmental attention to one's physical, psychological, emotional, and spiritual needs. Such attention requires quiet time and space that supports self-reflection. B is for balance. Balance of activities at work, between work and play, between activity and rest, and between focusing on self and focusing on others. Balance provides stability and helps staff members be more grounded when stress levels are high. And finally, C refers to connection. Connection to oneself, to others, and to something greater than the self. Connection decreases isolation, increases hope, diffuses stress, and helps us share the burden of responsibility for client care. It provides an anchor that enhances our ability to witness tremendous suffering without getting caught up in it. This completes the lesson on trauma-informed care. Please observe the additional resource material that is in the lesson media section of this lesson, specifically the information from SAMHSA regarding trauma-informed care and the worksheet for the pro-qual or the self-assessment for secondary traumatic stress. When you are done with this lesson, please remember that you have to complete the quiz with a passing score of at least 70% in order to complete the lesson. Thank you.